and welcome to Digest This, where we discuss clinical topics in gastroenterology. My name is Jennifer Tham. I'm a gastroenterology trainee in the west of Scotland, and today's topic is the role of dietitians and diet in inflammatory bowel disease. And I'm delighted to introduce Anna Julian, a dietitian in Glasgow Royal Infirmary with a specialist interest in inflammatory bowel disease. Welcome, Anna.
Thank you for having me.
So I guess the first thing that we should discuss is that diet and nutrition is really important in inflammatory bowel disease. And I think that as clinicians we do recognise that, but I think we struggle sometimes to give our patients kind of practical advice. So I think what maybe would be a good starting point would be for you to talk through your role as a dietitian with a specialist interest in inflammatory bowel disease.
Absolutely. So as dietitians, we take the science and we transform that into practical advice for our patients. As a gastroenterology dietitian and a dietitian working with adults with gastrointestinal problems and liver problems, my colleagues and I work with both inpatients and outpatients to try and support them. Historically, with diet and IBD, it's been very much a supportive role. We would often get patients who were referred perhaps for a little bit of nutrition support advice, or patients where all other treatments perhaps had been exhausted, whereas now diet is really coming to the fore, not only as a supportive nutrition support therapy, but as a standalone therapy to try and induce remission. So I suppose primarily our role as dietitians is to treat malnutrition, and we also have a role in terms of preventing malnutrition too. So for example, in IBD, patients who might have stricturing disease, no longer able to maintain their standard diet, no longer able to eat solids in the same way as they did before, we can work with them to think about a soft diet, a liquid diet that meets their nutritional needs in terms of getting their energy, their protein, their macro and micronutrients, but minimising that risk of obstruction. Patients commonly recognise diet as a really important part of managing their symptoms. Crohn's and colitis have done surveys in the past, and more recently Glasgow University have done a survey that shows that over 50% of patients feel that dietary manipulation is important for them to manage their symptoms. So we can have a role there in supporting that. And then thirdly, we are a fundamental part of the MDT in terms of inducing and maintaining remission in Crohn's disease with EEN, which I think we'll probably talk a little bit more about. And then in my role as an advanced practitioner in dietetics, I have a role in terms of keeping up with the evidence, being able to work with researchers locally as well to make sure that we are implementing the most up-to-date evidence in our practice day to day.
That's great. And as you say, patients do recognise the importance of diet and nutrition in inflammatory bowel disease. And one of the common questions that I get asked in clinic is, what food should I be eating? What food should I be avoiding? And I sometimes struggle to answer this question. What kind of advice would you give to me to give to the patients?
Food is such a fundamental part of our lives, isn't it? So it's constantly at the forefront of patients' minds. And there are a few foods that are kind of commonly come up, I suppose. The first of which are the irritant foods, something like caffeine, alcohol, spices. We know that patients with IBD are very frequently avoiding or having a low spice diet because they find that it interacts and causes symptoms. I would say to patients that avoiding those guys is absolutely fine. The problem comes when patients exclude the big food groups. So they might exclude lactose, gluten, fats that they feel have an effect on their symptoms, but we need to make sure that their diet is complete and holistic. So if we take lactose, for example, there have been studies that show that actually in the IBD population, the incidence of lactose intolerance is about the same for patients with quiescent disease as the general population. But potentially when there's that bit of inflammation and the gut is more sensitive, we see lactose intolerance more commonly. What I would say is for patients to try and adopt a systematic approach in terms of their exclusion. So if they feel that there is a relationship, quite often that can be threshold based with something like lactose. A glass of milk contains 12, 14 grams of lactose, where a piece of cheese, some of those fermented dairy products, yogurts contain significantly less and might be tolerated okay. So rather than a blanket exclusion, having a look and trying to perhaps use a food diary to go through and kind of think about when they eat something, what symptoms are they having and how often, and challenging that, not just taking it as gospel, Similarly, gluten comes up quite a lot, and we don't know whether there is a greater gluten sensitivity in the IBD population. Around 25% of patients with IBD report a sensitivity with gluten. And then fats. So there are patients that find a high-fat diet or even a kind of moderate fat diet can be problematic for them. Again, I would really strongly suggest that they look at thresholds with fat and don't exclude all types of fat, particularly if they are at risk of malnutrition or they're losing weight. Fat can be a really valuable source. So I think for you as the clinician, it's really helpful for us all to be thinking about diet, supporting patients as much as we can, because we know it's so important to them, and trying to advise them to think systematically, complete a food and symptom diary. Is it a particular nutrient like gluten, like lactose, or actually is it around the quantity of something they're eating, the sauce that they're putting on, and trying to really kind of break it down. And if they're struggling, to seek help from a dietitian if they can access one.
That's really quite useful information, thank you. Would you have any information or advice that you would give to patients specifically with ileostomies or colostomies?
So the more that we can do to reassure our patients going for surgery, the better. Following surgery, a solid diet will be introduced slowly. And one of the things that we see quite often is that people stool a little bit there. They might continue to have soft things. They might really struggle to bring in fibrous foods into their diet. And if you think about it, it can be really nerve-wracking for somebody who's had IBD, perhaps had problems and symptoms for months, maybe even years, to then go through that process of bringing foods back into the diet. And there are lots of myths out there as well. If you go onto the internet, if you Google, you find all of these sites that suggest you shouldn't be eating this and that, where actually nothing is out of bounds. One of the things that commonly comes up, people are afraid that they might eat something that would block their stoma. And actually, there are foods that perhaps are a little bit tougher, insoluble fibres, for example, nuts, whole grains, peels, that might be more risky. But actually, it's about managing that risk and perhaps trying that food in moderation, kind of being aware, but not necessarily avoiding that food. And similarly, odour is something that people are really worried about, but it's the same foods that we would probably all worry about a little bit. It's those windy foods like your broccoli, your cauliflower, your sprouts, your asparagus. It's things like fish, onion, garlic. And it's trying to reassure patients that often it's just when they're changing the bag, it's not something that everybody can smell. And for them, it's trial and error, it's patient preference. But generally, those odours often stay in the bag and they don't need to worry about them.
My next question is about exclusive enteral nutrition. It's obviously well used and well recognised in the paediatric sector, and we do use it in the adult sector, but when would you advise that we think about using it, and what do you talk through with the patients, and what are the challenges they experience with that?
Oh, I'm glad you asked. One of my favourite topics, EEN. So exclusive enteral nutrition, EEN, is something that we've done a small amount of for years, but it probably was with patients that were perhaps difficult to treat, whereas it's really come to the fore now. And there are bits of evidence that show, not only in paediatrics, but in adults, that it is a really effective treatment to induce remission, to induce mucosal healing, to support nutritional status as well. So the guidelines now are much more, include it much more readily. So the ESPEN guidelines on clinical nutrition in IBD that were out last year do suggest that it's an effective therapy in anybody, not just in paediatrics, which is brilliant for us as dietitians because we've known that it can be really useful. It's obviously a challenging treatment. You know, it is a liquid diet, which we tend to promote for around 6 to 8 weeks. So in some ways, steroids are, you know, an easier treatment. Absolutely, they come with their side effects, but it can be an easier thing for people to get on board with. If somebody is going to take on an exclusive enteral nutrition, it's often because they want an alternative to steroids, and they perhaps find that steroids aren't working anymore, or they just don't want to take the risks that come with steroids. They might be worried about their bone health, something like that. All we find consistently is that if they're motivated, they're really able to work with us and complete the course of enteral nutrition, of exclusive enteral nutrition, sorry. The first thing to talk through is the indications, I suppose. We tend to use it to induce remission, first of all, but we also use it to help patients bridging to surgery, which might be in a few weeks, and we know that it helps their symptoms and potentially improves their nutrition ahead of surgery, which is paramount. This slide shows the pathway. It's a pathway from an Australian study, but we follow something very similar. Generally, the process is that the MDT will find appropriate patients for us and we'll make contact with them and talk them through the process in a little bit more detail. We start by working out their requirements. We find the right product that's the right fit for them. And then we start a period of 6 to 8 weeks liquid diet. Most patients will need around kind of 5 to 8 milkshake type drinks a day as part of that. Some will need a few more. We have a juice style drink as well that we can offer for those that don't get on very well with the milkshake drinks. And there are a few additional foods just to give them tastes. You can imagine that 6 weeks of a very sweet kind of milkshake based drink can be quite difficult. So there are broths, there are kind of clear mints that might give them slightly different flavours, but on the whole it's 5 of those drinks plus every day for a period of 6 weeks. We check in after 2 to 3 weeks. We find that, and there's some evidence to support that if somebody isn't feeling a clinical benefit within those 2 to 3 weeks, then actually maybe it's time to talk with the MDT and consider an alternative therapy. So we check in at 2 to 3 weeks. We support patients throughout their journey to try and keep them motivated. And, you mentioned there about the challenges. Obviously you can think of a huge amount of challenges with that, but for somebody who's perhaps experiencing really hard, challenging symptoms every day, and within 3-4 days they're having less urgency, they're going to the toilet less, they've got more energy, they're able to sleep better, and actually perhaps they weren't eating very well to begin with, food wasn't giving them the pleasure that it perhaps used to, then it can be really motivating in itself. So it's amazing how hardy people can be when they're taking on EEN.
That's great. That's really interesting. My next question is about low residue diet. So kind of well talked about, but what do we mean when we say what is a low residue diet, and what type of patient should we be thinking about using this?
So a low residue diet is a diet that includes foods that are lower in fibre. So it takes away insoluble fibres, particularly things that are hard to digest and would leave a residue on the gut. So nuts, perhaps challenging meats that are a wee bit fibrous, are all removed from the diet. We tend to focus on a low fibre approach now, so actually the term low residue isn't really used anymore. As you'll know, there are certain situations where we need a low fibre diet, so post-surgery being an example of that, or perhaps for somebody who has stricturing disease in their small bowel and there is a risk of obstruction. In terms of a low fibre diet as a therapeutic option, there isn't really any evidence for that. There's definitely no evidence that that might help with remission. There is evidence from patients, talking to patients anecdotally, patients will tell you that fibre is a big factor in their symptoms. So it's definitely part of our arsenal, in the same way that we'd explore irritant foods, we would look at fibre. The key thing with fibre, however, is that it's such an integral part of a healthy diet. So if somebody is flaring and they find that reducing fibre for that period of time is useful, that's absolutely fine as a short-term intervention. We then, as the MDT, need to be asking them, post-surgery, post that flare, are you now including fibre in your diet? In terms of health benefits overall, but also as a protective factor in IBD, we want to make sure that after that short period of time, fibre is then included and back in the diet for good.
Great. We know that there's lots of research at the minute going into diet and inflammatory bowel disease. Do you have any kind of preliminary results or anything that we could take into our clinical practice that we can use to help our patients?
You're right, absolutely. Diet seems to be everywhere in the world of IBD at the moment, which is brilliant. There are a few specific studies that spring to mind. The first being the CDED study, which looked at a Crohn's disease exclusion diet. So that's a diet that aims to induce remission in the same way as EEN, but it's a combination of a liquid diet with some choice foods, so high protein but low in animal products, removing additives as well. And that's something that someone would take for a period of a few weeks, quite restrictive at first, but then gradually reintroducing the variety of foods. And there's some really good results at the moment. It's very much in paediatrics, so I think we wait to hear. Hopefully there'll be a randomised control trial that will be adequately powered and that will show us whether this can work in adults as well. There's also the CD treat, so the Crohn's disease treatment with eating diet that Glasgow Uni has very much been leading the way with. That, again, aims to induce remission in the same way that EEN would induce remission, but with a selection of foods. So trying to make it easier for the patient, putting the patient at the centre, rather than having to have this restrictive liquid diet for such a period of time. The trials have been in adults as well as paediatrics. It's just not quite ready yet, but we're really hopeful that that will be something that we can use, in due course. Another thing that's always been kind of on our minds, I suppose, as dietitians, we see patients who go into surgery. They've often had a period of exclusive enteral nutrition to try and support their nutritional status, or perhaps try and bridge them to remission, but it hasn't quite happened and they've ended up needing surgery. But anecdotally, we've seen that they seem to have better outcomes post-surgery. They seem to be better nourished than some of the patients going into surgery. And actually, there is a trial going on at the moment called the Ocean Study, which will look at whether a period of exclusive enteral nutrition before surgery for kind of 6 weeks pre-surgery will have an effect on complications post-surgery, will have an effect on kind of patient perception of their complications and how they feel post-surgery. So that's really exciting. That's about to happen, and it will take some years to get those results, but something that I think could really inform how we practice. We know that prehab is so important, so it will really build on that for our IBD patients.
Following on from this kind of theme, I guess it's maybe a wee bit controversial, but everybody always says we are what we eat. Do you think that's the case for IBD? And I guess also with our current way of living, with ultra-processed foods, with additives and preservatives, do you think that we're kind of causing IBD in patients? What are your thoughts?
I think that's a really interesting question. The growing incidence of IBD around the world does seem to parallel the changes in our diet and this adoption of a more Western diet, which raises the question, are we contributing to IBD in that way? Guidelines recommend a healthy diet that's high in omega-3s, that's high in unsaturated fats, that's similar to the Mediterranean diet, perhaps. And there are several studies now that look at associations, big studies that have found certain factors to be likely to be beneficial, things like dairy, things like omega-3s. There are also associations which seem to be more negative. So the ratio of omega-3s to omega-6 fatty acids, so perhaps certain oils that we're including more in our diet now, where we should be trying to get more fish into our diet, and things like sugar-sweetened beverages, high sugar content of the diet, and then animal fats as well. I think it's really important to remember that these are all associations, and as is the trouble with research into nutrition, we often find associations. Vitamin D has been something that we've associated with almost everything, and it doesn't always come to fruition. Similarly with fish oils and inflammation, we can't always find a proven benefit. So I think we've always tried to promote a healthy diet. I think those factors we will keep promoting, but we just need to be really careful that we're not putting blame on people where they might feel, guilty enough. They might not necessarily express that that's how they feel, but we just need to be really cautious that we're not letting them take the blame for something that we don't actually know is something that has caused a problem. I do think emulsifiers and additives are really interesting. And again, the ESPEN guidelines from last year have suggested that we be cautious and we perhaps try and minimise our use of emulsifiers. So products like ice cream, dairy products, diet products rather, that try and create a mouthfeel without having to use fat. We maybe do just need to be more aware of how often we're using those as part of a healthy, balanced diet.
Yeah, it's a really interesting, quick topic, isn't it? That's great. Thank you for everything. I think my last question is, what would your take-home points be?
So I would say nutrition is fundamental. I think it's really important to consider what you can do as part of the MDT. So we all have a role in being able to direct patients to trustworthy resources at the point of diagnosis. Crohn's and colitis have some brilliant resources that we would recommend, and anybody can do that. Where somebody needs perhaps a little bit more help, whether it's because they're malnourished or because they're struggling to try and kind of identify patterns, or their symptom burden is great, then use your dietetic team. Hopefully most teams will have a dietitian attached that they can use. And for patients, I think it is just really being aware of what they're eating, trying to ensure that they are having a healthy, balanced diet with fibre included as part of that where possible.
Well, Anna, thank you very much. That was an excellent run through of your role as a dietitian and diet in inflammatory bowel disease. So thank you very much.
Thanks for having me.
And all that's left for me to say is thank you for joining us for Digest This.